So I think that was an outstanding presentation from Dr. Chung. But how many of you really want to go to him and have him do what he did just now? No, nobody does. And hopefully, I'll give you some idea of how you can avoid that fate. Like him, I'd like to put him out of business, but I don't think we're there yet, as you'll see. We still need him. We'll keep him around for just a little longer. Okay, so until recently, people with VHL were managed almost exclusively by surgeons and ophthalmologists. And if I tried to enter a room where there was a VHL patient being seen, Dr. Chung would probably throw me out and say, "You have no business here. What are you doing here?" I've, of course, been actually, as a medical oncologist, been seeing patients with VHL for close to 20 years now. And the reason is, even though we have effective treatments surgically, and as I've shown you here, you do surgery for a variety of reasons. You either, in the case of those tumors that can spread beyond the organ where they arise, you'd want to take these tumors out to prevent the risk of metastatic spread, or as Dr. Mushfeghi and Dr. Chang showed you earlier today, you can have problems from tumors that they're not going to metastasize, but they're going to grow and cause problems. And so you want to get rid of them one way or another. And that was really the basis for the management approaches that developed over the years to deal with tumors arising in various organs. For those tumors that do tend to metastasize, once they metastasize, we don't really know how to cure them. And there have been no VHL specific studies for those tumors, but there are people who don't have VHL who have similar tumors, and we sort of know how to treat them, and we use the same principles if the tumor does spread beyond the organ in which it arose. But the goal really, as far as possible, is not to let them spread, to try to deal with them before they spread. So this slide's probably not even necessary after Dr. Chung's presentation, right? I mean, everybody here is looking for an alternative. But I think these points were made earlier by several speakers. People have to, you guys go through multiple surgical procedures, and none of them's easy. And the more you go through, the harder it becomes. You then start losing kidney function. You start having neurologic problems, pancreatic problems, adrenal insufficiency, all of which we'd like to avoid if possible. So how do you even start thinking about treating these tumors with a drug? You start by trying to understand what's driving these tumors. And the ball was set rolling probably in the early 80s. Nikki this morning in her talk talked about Doctors Linehan and Burton Zabar at the NCI. They started looking at families with VHL, and they said, there's certainly something here that we should be able to identify, because these tumors occurred in random families. They said, there's got to be a gene. We just need to identify that gene. That was easier said than done, as others have said before me today. It took from the early 80s around 10 to 11 years for them eventually to find a gene that was missing or altered in the germline of people who were affected by this condition. And they very creatively named the gene the VHL gene, and found that there were very specific areas within the gene that could be altered and to render that gene non-functional. We also found subsequently that people who get the more common sporadic of clear cell kidney cancer, these are not kidney cancers that run in families, but the kidney cancers that arise in these patients look identical to the kidney cancer that you see in VHL patients. Those patients also had the same mutations. But I don't know if you recall what Nikki told you earlier, the difference between germline and somatic mutations. In these sporadic patients, the mutations were somatic and not in the germline. From there, it took around 10 years or so for us to understand why a problem in that one single gene would lead to tumors in different organs. The RCC, or kidney cancer, was really used as the model to study these processes, but some of these probably apply to other forms of tumors associated with VHL as well. So again, this has been explained to you before, so I'll very briefly talk about this. And what I'm trying to show here in somewhat complex fashion is that normally VHL plays an important role in regulating the cell's response to what it senses as being the oxygen tension in its environment. If it feels that there is enough oxygen, it quickly takes away these yellow proteins that I've indicated there called hypoxia inducible factors. And remember that term because it'll appear many, many times in this talk. But if the cells feel that there isn't enough oxygen, we need to find ways to get more oxygen to the tissue, then these yellow proteins start building up. And they do a lot of things. They promote blood vessel formation, they promote uh, nutrient delivery to that area, and many other things, all of which try to heal the sense of, I don't have enough oxygen, I need to do something. What happens when the VHL gene is altered is that the cells are always thinking that they don't have enough oxygen. So these various proteins that are only supposed to be turned on at some points in time are turned on all the time. And that really leads to these tumors. A lot of the treatments that people have developed for the sporadic common forms of clear cell kidney cancer came from understanding this process. And what people were able to do was develop drugs. All these, each word in red is a drug that we've used effectively to block clear cell kidney cancer, but not in patients with VHL, patients with a sporadic form of clear cell RCC. And I'll tell you why that is in a minute. But what we also found around 20 years or so ago was that we'd like to target the hypoxia-inducible proteins directly, but there are many kinds of hypoxia-inducible proteins. And around 20 years or so ago, two somewhat different approaches coming from two different groups both showed the same thing, that of the various forms of HIF2 is the more important driver of cancers in VHL patients. So people started looking to see if they could directly target HIF2 rather than all these changes that occurred as a consequence of HIF2 going up. It took a long time. It turns out these proteins are not easy to target with a drug, but eventually a group of investigators found a way and came up with several drugs that could actually achieve what we wanted, which is directly block HIF2 alpha rather than going downstream and trying to block these various other things that happened. Of these many drugs, the one that's made it farthest into the clinic is this drug called belzutifan. You may have heard it by other names, PT2977, MK6482, and God knows how many other names. But it's known as belzutifan, and there's a trade name for it too, which I prefer to remember belzutifan. So when belzutifan became available, we found in a phase 1 study that it was safe or relatively safe. We said, let's look to see if we can do anything with this drug in patients with VHL, whether we can help people with VHL control these tumors. You don't have to remember anything here other than that we put 61 patients on the study. The study was done at multiple centers across this country, as well as 3 centers in Europe. Patients had to have a confirmed diagnosis of VHL, of course, because that's the purpose of the study. They should not have received prior systemic treatment for their tumors. Their tumors should not have spread beyond the organ and the kidney, especially, and that patients should have at least one kidney tumor that we could clearly see and measure and follow. Although the goal was primarily to look at kidney tumors, we were also interested in seeing what happened in tumors in other locations. So that was something that we carefully followed on the study. Last but not the least, we wanted to see how patients did with this drug, because it's we can kill almost any tumor by giving things that will kill the patient as well. That's not the goal. We want to what we want really is to try and maintain the patient's quality of life, make sure that they're able to tolerate this treatment well while shrinking the tumor. 61 patients, like I said, on the study. All the patients, of course, had a kidney tumor because that was a requirement. All 61 patients also had some kind of pancreatic lesion. In many cases, they were just cysts or cystadenomas, if you remember the talk from Dr. Kebibi earlier today. But 22 of those patients also had pancreatic neuroendocrine tumors. And to me, these are the most worrisome tumors that arise in the pancreas because they can spread and metastasize. 50 of the patients also had CNS hemangioblastomas, which you've heard from other speakers before is one of the most common manifestations of VHL. So based on the results from the study, I know Dr. Srinivasan is going to go over this data in much more detail. I'll also go over some of it in a minute. But based on what we saw in the study, the FDA felt that this drug was active enough to and safe enough to treat people with certain forms of VHL-associated tumors, specifically kidney cancer, pancreatic neuroendocrine tumors, CNS hemangioblastomas, and made the proviso that you can treat these patients as long as they don't need immediate surgery, right? Because surgery has long been established as the gold standard for treating many of these tumors. And so, if somebody we thought needed surgery, we would more likely than not take them to surgery. But if they didn't need immediate surgery, then this drug was deemed a reasonable option. So when we start thinking about treatment with drugs for VHL patients, I think of many things that we should achieve in order for a treatment to be successful and useful. What are some of those things? Number one, and these are a little different from the 5 things that Chris told us about earlier today. Those were really fantastic. But I again come up with 5 aims that I think we would like to accomplish. There are many more, but I've chosen to focus on these. Um, First and foremost, you don't want the tumors to continue to grow because that's bad. So you either want to prevent their growth or actually shrink them. You would think that in doing so, you could possibly avoid surgery or delay surgery. But that's, I think, another major goal. We want to try and find an alternative to surgery while doing everything that surgery does. We need to have very acceptable side effects, both in the short term and in the long term. Dr. Chung, I think, mentioned you may be able to, I think Dr. Mushfeghi did as well, you may be able to get away with a few side effects right now, but you also have to think about long-term consequences of everything you do. You guys have tumors come up at any point in your life, all the time, and we see you. Patients I've seen 20 years ago are still with me, and we treat you guys over your lifetime. So we think not just about the next 2 months or 3 months or 6 months. We think about the next 50 years. So we want to do something that'll have acceptable short as well as long-term side effects. And of course, we want to prevent metastatic spread. Just because we are able to shrink a tumor doesn't mean that we are also going to prevent it from spreading. It's not an unreasonable assumption that would happen, but I'd like definite proof at some point that is indeed the case. And wouldn't it also be nice if we could prevent new tumors from coming up? Right. So these are some of the major goals. Let's see what we've actually accomplished with this study so far. So have we prevented tumor growth or caused tumor regression? Absolutely. I think there's no question about that. We've seen tumors shrink in all the organs where we've looked for. These tumors, once they shrink, tend to stay shrunk for a period of time, prolonged periods of time, prolonged being a relative term because we've only had around 3 years or so to follow people who've been treated with this drug. So we certainly need longer follow-up, but with the follow-up we have, I think we certainly see that tumors shrink to a significant extent. And this is what we see in the kidney, right? 64% of the patients had what we call a partial response, which means that the tumors shrink by at least 30% or more. And on the right side, you see in how many patients tumors have shrunk and how much they've shrunk. So every bar that's pointing downwards is one patient in whom the tumor has shrunk. And the depth of the bar tells you how much the tumor has shrunk. These blue bars indicate that the tumors are completely gone. So 4 of these patients, the kidney tumors went away completely. Many of the others, the green have this magical 30% or more regression, and the yellows haven't got there yet, but they're getting there, maybe getting there. This is just another way of looking at the data. The longer the bar is, the more duration the patient has remained on study. So it goes out to something like 4 years or close to 4 years. some patients come off early, but many patients seem to stay on the drug for prolonged periods. In fact, when we looked at an average of 3 years or so, we found that 38 of 61 patients remained on study. And of the 39 patients who actually had this partial response, 34 of those remain on drug. So again, some early indication that many of the responses are durable, but again, not all patients have stayed on. So there are some issues that we have to deal with, and I'll get to that in a minute. I told you we were also interested in seeing what happened outside the kidney. Similarly, similar to what we see in the kidney, we see tumors shrink very nicely in the pancreas, in the central nervous system. What about the eyes? Even though the FDA approval does not encompass the eyes, we clearly, definitively, very reliably see tumors in the eyes shrinking with this drug. It's just that we didn't have enough patients, and as oncologists, we're not very used to showing how eye changes are. We work very closely with our ophthalmologist, Dr. Wiley and Dr. Emily Chu, and we're coming up with ways to try and demonstrate convincingly for the FDA that this drug does work in the eyes as well. With other tumors like pheochromocytomas and some of the other benign tumors, we don't have much experience. We didn't have enough patients with those tumors for me to conclusively say whether or not this drug will help. My gut feeling is it probably will, but I can't prove it at this point. So I think first of 5 goals, I think we've shown that we've made some headway. Can we delay or avoid surgery by doing this? I'm going to give you some examples. So this is a 45-year-old woman diagnosed 10, 15 years before she came to me. Had undergone a left partial nephrectomy for multiple kidney tumors at that time in her 30s. Had a recurrence of multiple tumors in both kidneys. Also had pancreatic neuroendocrine tumors come up, at least 3 tumors. And if you remember what Dr. Kebibi told you earlier today, you don't want people messing with your pancreas if possible, right? I mean, you all know this already. So she also had some brain tumors in her brain and on her spine, small ones, but they were there. And she came to us and said, if there's anything I can do to avoid surgery, I'd please do it. I certainly don't want anybody touching my pancreas. And those were her words. And so we put her on the study. And what I'm showing you on the left are 2 tumors. I don't know if you can see them. They sort of stand out differently from the rest of the kidney. So one on the right kidney, one on the left. She had a few others as well, which I'm not showing. After treatment, it's very hard to see the one on the right. The one on the left is significantly smaller. It's still there, but it's significantly smaller. We were unable to see her pancreatic neuroendocrine tumors after a few cycles of treatment. So I think at least in this case, we at a very minimum managed to delay treatment. Delay surgery. Second case, 30-year-old man diagnosed with VHL at the age of 12. Had multiple retinal and CNS hemangioblastomas at that time, had multiple procedures, became legally blind, sadly, despite the best efforts of the very, very skilled ophthalmologists. Also had multiple CNS surgeries, and with each one developed more deficits and paresthesias and all kinds of other symptoms that people who have CNS surgeries undergo. You had a very detailed description from Chris earlier today of what people go through when they have these kinds of surgeries. And when he came to me, he had new tumors in the brain and in the spine, and you can imagine he was desperate to avoid surgery. Also had multiple tumors in the kidneys that were getting to a size where Dr. Chung would have suggested taking them out. Yeah. So we treated him with this drug, and very gratifyingly found the tumors both in his spine and in his cerebellum on the top panel showed reliable and consistent and prolonged progression. His kidney tumors also shrank a little bit. Some of them stayed stable, and we were able to head off surgery, at least for now. So I've shown you a couple of examples. What happens if you look at the whole patient population? And this is a graphic way of showing what we found when we looked at the need for surgery in these patients. On the left side of the screen, in the gray or light green bars, are patients. Each bar represents a patient, and each dot or triangle or square represents a surgical procedure. So if you just look at the 4 years, and we have data going back 10 years, These patients had a total of 87 surgical procedures done overall in the 61 patients. 46 of them had needed some kind of surgery. If you go back 10 years, that number was over 300. On the right, you see what happened since they went on the drug. Now, this is all kinds of biases that are introduced when you do an analysis of this kind, but at least at this short follow-up, we find that there were very few surgical procedures needed. They're not zero, but there were very few. And certainly the density of those dots, I think, is very different on the left and on the right, suggesting, again, with an early look, we need more follow-up, but an early look suggests that maybe we are decreasing the need for surgery with this drug. Do we get acceptable long and short-term side effects? Why is this important? So let me go back and give you a little bit of history. I told you that if, agents that target, VEGF receptors and other, targets that are useful in metastatic clear cell kidney cancer of the sporadic variety may not necessarily be useful in patients with VHL. Why do we say this, and how do we know this? Because we've done some studies. Both us and other people have done some studies, and we found that a vast majority of those patients, even though the drug was somewhat active in some situations, 2/3 more or less of those patients needed to come off because of toxicity. And if you looked at how long patients were able to stay on drug, less than 6 months. So you're not really going to have an impact on a disease that affects people lifelong with this kind of approach. So we needed something better. And belzutifan does seem to be better. There is no drug I know of which is effective and doesn't have side effects. So belzutifan does have side effects. But most of the side effects we saw with this drug were mild. Grades 1 and 2 is the technical term we use, which to physicians means the drug is well tolerated. Patients may disagree, and often do disagree with this classification. Some things that we may call grade 1, the patients will say, I can't deal with this. I need to go off study. So that is very important as well, not just what some book tells us to grade it as. The most common side effects were anemia. Almost 90% of the people got it. It was an expected side effect. Based on the mechanism of this drug, and I'm happy to discuss this with you more, we expected people to get anemia. In fact, if people got anemia, we said, oh, the drug's probably working. And then fatigue, which can often accompany anemia, are some of the more common side effects. You may have heard about hypoxia. So any of you had a pulse oximeter placed on their finger and know that it should be in the high 90s. We've seen patients with this drug get much lower, in 80s and 70s and so on and so forth. So it was a cause for concern when we started treating people with this drug with VHL. Thankfully, we only saw one case of transient hypoxia in this population, and I'll elaborate on that just a little bit more. So sure, I showed you in the previous slide that the drug was supposedly well tolerated, but the most common reason for people discontinuing this drug was patient decision. And the patients had some reason to say, no, I'm tired of this drug, right? Some people said, I'm tired of being on the trial. I want to, now that the drug is FDA approved, I'd rather get this off trial. The trial requirements are often, very burdensome. You're asked to come every 3 months for scans, more blood tests than you would in the standard of care setting. So some people said, it's easier for me to get it off protocol. But some patients went off it because they said, yeah, I don't think I know you don't think I have very bad side effects, but this is hard on me. It's affecting my quality of life. I need a break. So there are side effects that cause people to go off this drug. Much better off with this drug than we were with previous drugs. But there are some side effects. And most of these side effects stem from anemia or fatigue, and people saying, I'm not able to do what I was able to do previously. I had a very active lifestyle. I know people who are marathon runners who are not able to do it as easily as they used to. And they said, this is important enough for me that I want to go off the drug. So something to keep in mind as we start thinking about whom to treat, how to manage side effects, and so on and so forth. Because anemia is the most common side effect, I want to go over this a little bit. I told you that the pathway that HIF controls leads directly to production of red blood cells. There's a protein called erythropoietin that's made if HIF is found in abundance. And if you block this HIF2, erythropoietin goes down. Without erythropoietin, you're not going to make red cells. So you become anemic. Most patients on the study had anemia. The course is fairly predictable in the majority of patients. In the first 4 weeks or so, we start seeing the hemoglobins drop, and then they sort of stabilize and maybe go up a little bit or stay the same. Uh, in most cases, the hemoglobin stays at a level where people are not too badly bothered by it. A lot of the patients I see with VHL have hemoglobins in the 15, 16, fairly robust range, at least in the higher end of normal, if not above normal. And so they can actually afford to have a little bit of anemia. Even when the hemoglobin goes down to 11, 12, 13, they're able to function fine, and they're able to cope with this fine. But if the hemoglobin just does drop below that, 9 or 10 grams deciliter, then, or if they become symptomatic, that's when you need to intervene. So how do you intervene? You can stop the drug, maybe reduce the dose after a while to see how they do. We also always look to see if there are other causes for anemia. Some of these people may be iron deficient or deficient in something else, and if so, we correct that. In some patients, we've had to give back the protein that this drug is blocking, erythropoietin. We're only giving back erythropoietin. We're not giving all the other things that this drug helps, HEF2, the HEF2 inhibition blocks. So we can give erythropoietin. It's been a drug that's been around for management of anemia for many, many, many years. And there are some risks associated with erythropoietin. Again, I don't have time to go into it. So we have to be very careful whom we give it to and how we give it to them. But a small proportion of patients did need erythropoietin. Many of them very transiently, a few doses, and then they were okay. Because there are some dangers associated with giving this class of drugs, the erythropoietin and similar drugs, the FDA has sort of cautioned people that these drugs should be avoided. And again, I'm happy to discuss at length with you why that is the case. But in the context of this trial, we were able to give erythropoietin, and we did to many people. Occasionally, patients need a red cell transfusion, and in some cases, they've had to discontinue the treatment altogether. Very briefly, I'll touch upon the hypoxia that I talked about. Only one of 61 patients, as I said, on this study had this. Seems to be much more common in patients with metastatic clear cell kidney cancer, and that could be for many, many reasons. Those patients generally tend to be older. They have other medical problems, sometimes cardiac and lung problems, which seem to be associated more with hypoxia. Regardless, anybody that goes on this drug or a similar drug needs to be closely monitored for this. The last 2 points, can we spread distant metastasis? We don't know. We just don't have enough experience with this. That's going to take years to figure out. Okay, but we'll be following that on the study, and I think the real world experience will also tell us if people have small tumors and we start treating them before they're 3 centimeters, we should not see metastatic disease. And if we do see metastatic disease in someone, that would be a red flag. So I think it's something we would watch for very, very, very closely. But I don't have an answer for you today. The same thing about prevention of new tumors. This is going to take some very specialized studies and very long-term follow-up, really, to help us answer these questions. Okay. So we've hit some of the points. We haven't hit some of the points yet, but what we do know is that we do have, for the first time, a drug that the FDA has approved to treat patients with VHL. And because of this, we now have the ability to treat some, not all patients, some, with this drug. I want to caution everybody that this is not a drug that everybody should get or can get. I also would say that this drug, to extract the most benefit from this, should be used in conjunction with conventional management strategies that you've heard about from other speakers today. We continue to learn how best to use this drug. We don't know today the way we're doing it is the best, but science will help us figure that out in the long run. So we do have some tools at our disposal now. How do we use these tools best? Time will tell. I'm going to spend the next few minutes, I hope I have some more time, trying to address some of the questions that have come up in my mind, also in the mind of other people who both treat this condition, as well as those of you who are thinking about this treatment or have already taken this treatment. What's the best way to give this, and how do we select patients that are appropriate for this, right? We know that it's probably not practical to give a drug like this to a patient throughout their life, especially if you start young, right? I don't think that you can necessarily give most people a drug like this for 30 years or 40 years or 50 years. Chances are, if you stop giving the drug, the tumor will come back because you've not changed the basic problem that is leading to the tumors. This is a temporary solution. As long as the drug is on, it has the potential to control these tumors. Um, it's important to keep in mind that anytime you treat a patient with VHL, you want to do it as part of a big multidisciplinary team, because uh, that's the reason you've heard from neurosurgeons and pancreatic surgeons and ophthalmologists and urologists and medical oncologists today and genetic counselors, because this is a complex problem and it needs to be very, very thoughtfully addressed, and that takes a big team of skilled people who have experience in treating VHL. When I look at patients with VHL and consider this treatment, I take into account many factors, only some of which are listed here. How much tumor, how big are their tumors? How many tumors do they have? How many surgeries have they had? How imminent is their next surgery? How quickly are their tumors going? How old are they? Do you guys have any preference about whether you want this drug or not? Right, and that's a very important factor. Uh, how sick is a person from non-VHL related problems, or even as a result of VHL related problems? So these are some of the considerations that take into account. There is no formula for saying this person can go on or that person can't go on. But I'll try to, uh, you know, illustrate a couple of examples where you may be able to think one way or another about the best way to deal with uh, administering belzutifan in given circumstances. Again, I want to emphasize belzutifan should complement, not supplant surgery at this point in time. Patients, if they normally would need surgery, as I said at the beginning of my talk, we typically proceed with surgery and don't use belzutifan as an alternative to surgery in people with large tumors and stuff like that. Because, as I said, we still don't know if by doing that we'll reduce some of the uh, uh, problems associated with those big tumors. We don't know for sure that by treating these patients with belzutifan will bring down the risk of metastatic disease. By removing the tumor, we do think we have more experience trying to prevent metastatic spread that way. So I'm going to propose a couple of scenarios and see what people think, or what I think about whether or not these patients should or shouldn't get belzutifan. Start off with a young person, a 20-year-old woman with a history of multiple CNS hemangioblastomas. At age 12, had a resection of a cerebellar hemangioblastoma. Age 16, another resection. Age 19, another resection. With each of these, the patient suffered some complications and has had significant neurologic sequelae from those surgical procedures, and now has multiple new growing but asymptomatic hemangioblastomas in the spine and cerebellum. So this is the kind of patient where I may say belzutifan may be a reasonable consideration, because we really do want to avoid that next surgery. And if we wait for that next CNS hemangioblastoma to become much bigger or start causing symptoms, we may have lost a window. So this is somebody with whom I would have a serious conversation about the pros and cons of starting belzutifan therapy, and probably lean towards starting it. On the other hand, we have this 44-year-old woman diagnosed at age 30 as a result of screening prompted by a known family history of VHL. The patient's been very, very good at following surveillance recommendations. So you tell her to come back in 6 months, she'll come back in 6 months. Whatever you tell her to do, she does. At the age of 36, she had a 0.5 centimeter right renal tumor. And over 8 years, it's grown from 0.5 to 1.4 centimeters. This is one of the a slower growing tumor than average even. Has some small cerebellar hemangioblastomas and spine hemangioblastomas, very small, asymptomatic, and relatively stable over the last few years. Patient is otherwise healthy. So based on what I've shown you, this patient is unlikely to require surgery in the near future. Very, very compliant with surveillance. And this is somebody in whom I may shy away from belzutifan, because there is no immediate benefit that I can see. And a patient may need belzutifan or benefit from belzutifan sometime later in the course of their disease. But at this point, probably not. Last couple of minutes, I will talk about the other problem we face with patients who deal with this, who get treated with this drug, and that is one of resistance. I briefly alluded to this in the beginning of my talk. 6 of the patients enrolled on the study had a growth in their renal tumor uh, while they were on this drug. And so that is, to me, saying that these tumors are escaping control from belzutifan. And this is something I think with time we're going to see more and more of. Uh, we don't yet understand why that happens. What are the mechanisms underlying this escape? And understanding that is going to be very, very critical for us to figure out how best to deal with this. And again, this is something we are in the process of doing, and we will try and figure out if there are certain kinds of tumors that are more likely to escape control. What are the factors that lead that escape? And once we understand that process, we could potentially then come back and find a way to fix that. But we're in the very early stages of even trying to figure out what's happening. Uh, but one of the things I think we can potentially do to combat this resistance is find new ways to treat VHL. People have been studying VHL for 30 years, and it's hard to come up with new ways to target this pathway every year, but people are trying. What I'm showing you here is one such approach. This is, again, it's a very complex slide. All I want to try to convey to you here is that there is a protein called HSP90, which is responsible for maintaining the levels of many proteins in the cell. If this protein HSP90 senses that some protein is not looking right, one of the things it does is binds to it and destroys it. And when VHL is altered VHL protein, especially those with missense mutations, where there is just one area where the protein isn't right, and that changes the function. These proteins tend to get picked up by HSP90 and quickly degraded. And there are some studies to show that even though those proteins are not normal, they do still retain some function. So there's some value to preventing this degradation of the mutated or altered VHL protein. And that people have shown in the laboratory can be done with a drug that we call a HDAC inhibitor. It's a drug that's used in other conditions, some forms of what we call myelodysplastic syndrome, condition that can lead to leukemia. And that drug or that class of drugs has been shown in the laboratory to reverse this process. So what happens as a result is, even though the protein is not normal and is misfolded, it's prevented from being degraded as rapidly, and the VHL protein still retains some function. To try and see if this is something that happens in humans, Dr. Chitiboyna, who's a neurosurgeon, very smart neurosurgeon who works at the NCI and NIH actually, uh, has opened a study to look at the effect of one of these drugs, a drug called vorinostat. And what he's planning to do is take patients who are about to go into CNS surgery. They have a hemangioblastoma that needs to be removed. So he's going to treat them for a few days, take the tumor out, and see what's happening in the tumor. He's essentially going to ask if what he saw in the test tube is actually going to be seen in the humans as well. So we're very eagerly looking to see what this trial shows, because I think it may provide some clues as to what we can do next to target VHL. Another approach, an approach that came out of Dr. Bill Kaelin's lab in Harvard, is the following. They know that there's a protein called cyclin D, which is upregulated by HIF as well, just like erythropoietin and VEGF and PDGF and all those other proteins. And what he showed was that if you have a tumor cell, without VHL, and you also in that cell inhibit a group of proteins called CDK4 and 6 in particular, then those cells tend to die. And those proteins, CDK4 and 6, are activated when you have high cyclin D. So VHL seems to be controlling that process, or loss of VHL. So if in a cell you don't have VHL, and on top of that you somehow inhibit this CDK4/6 protein, then those cells can't survive and they die. We do have effective ways for inhibiting CDK4 and 6. There are drugs that inhibit this pathway that are active in breast cancer and are FDA approved for treatment of breast cancer. And so based on this data, there's a lot of interest in looking at that class of drugs in kidney cancer. We'll initially look at this in patients with metastatic kidney cancer because we want to understand the side effects and so on and so forth in those patients before we bring it to the VHL population. And we also know from work done in the same lab that if you combine those drugs with belzutifan or similar drugs, you seem to potentiate the activity of belzutifan. So we're very interested in pursuing this approach. These are just some experiments that sort of show this data. In the interest of time, I won't go over this, but there's a study that's now ongoing and others that are being planned to try and test this hypothesis in patients with metastatic kidney cancer. I'm going to stop in the interest of time. I want to stop by saying none of the work I've shown you today would be possible were it not for all of you guys and your families. Still remember in 2004 when I did the first study in patients with VHL. We were offering it to multiple patients, and one of the first patients who wanted to be on the study, volunteered to be on the study, I had a very long discussion and said, we have no idea whether this will work or not. It's an involved process. It's an experimental drug. We went over the pros and cons, and what I heard, still resonates with me. Said, yeah, you know what? I know it may not work, but we have to begin somewhere. And if it helps me, great. If it doesn't help me, but you learn something that can help my family or other people with VHL, I'm thrilled with that. And most people who participate in our studies have that mindset. And without this, we would never be able to do anything that we've done or want to continue to do. And this is the rest of my very, very talented group that has worked for years and years on this problem. Many people before me and some with me. And I'm sure there'll be some that continue to do this work long after I stop working on this. So thank you all for your attention. I'll take any questions if Dr. Chang tells me I have enough time.